79% will be in the duodenum, and the rest will be in the jejunum and ileum. Briefly, it is usually asymptomatic in the small bowel, but because it is in the duodenum, it will be very close to the ampulla, around 2 to 3 centimeter. So sometimes can cause pressure symptoms in the bile duct and might lead to choledocholithiasis. Okay, but as I said, the topic today is mainly about colonic diverticular disease. Just to give an idea of the blood supply, so when we come later and speak about the NGU and embolization, we'll have an idea. This is just a quick reminder. You have the inferior mesenteric and you have the superior mesenteric. Superior mesenteric is giving rise to the ileocolic, right colic, and the middle colic. And the inferior here is giving rise to the left colic, sigmoid, and ending in the superior rectal. Lower part of the rectum is supplied from the internal iliac through the middle rectal and inferior rectal, just quick revision. Okay, so what do you think are the factors that contribute to the development of diverticular disease? Why some people get it and others don't? So what is the commonest risk factors that you know about? Can someone answer?
Mainly diet.
Mainly diet. This is the main cause. This is the main reason. So that's why it is very common in Western countries here. And the diet is different from our diet. So dietary influence, how can that cause diverticular disease?
The Western diet has a low quantity of fibers, so
that's
the
right.
stool bulk is small, and
that's right.
The patient has to strain a lot to
okay.
expel the stool,
so that can lead to, and that can cause increase in the pressure inside the colon. Yeah, so that may lead to increase in the pressure inside the colon, and then it will the protrusion will happen in the weak areas. Which part of the bowel had the weak areas? So protrusion mainly will happen in which part of the bowel? At the site of
the entry sites of the vasa recta.
That's true. So that will be the weakest point. So with the increase in the intracolonic pressure and that weak points, that will lead to diverticular disease. Okay, so other factors. Age. So the older the people, the most likely they will develop diverticular disease. They said 50% of people above 60 years of age, they will have diverticular disease, and 70% who are over 80 years will develop diverticular disease. And the reason for that, they think they will have weak bowel wall because the change of the collagen, the structure of the bowel wall. Okay. Lifestyle factors. What does that mean? Give me example.
Smoking, exercise.
Smoking, that's correct, yeah.
Exercise.
Lack of exercise, very good, yeah.
Also obesity.
And obesity, that's the three main factors, yeah. So when we talk about lifestyle factors, we'll talk about these three factors. Medications. Anyone can suggest any medications that can lead to that? Non-steroidal anti-inflammatory drugs and steroids even, that can all lead to weakness and lead to diverticular disease. Genetic factors, they are less well defined, but people are saying there is a connection and it can lead to diverticular disease, but it's not really the main reason for diverticular disease, and the main contributing factor will be the dietary influence. People talk about diverticulosis and diverticulitis, so there is difference between the two. Diverticulosis means presence of diverticula, and diverticulitis when there is associated inflammation and infection. And in this picture here, you can see feculis at the neck of the diverticulum, that can lead to change in the bacteria flora here, and that can lead to infection, micro and macro perforation within the diverticulum. You already spoke about that, so it is very common in industrialized countries, and the incidence is increasing with age. Okay, any question so far? If no question, I will ask question. What is the commonest presentation for diverticular disease?
Bleeding.
طيب قبل ما السؤال شوية تريكي. Asymptomatic, that's right. So it is commonly asymptomatic. Okay. Yeah. So usually we just find it incidental finding while we're doing colonoscopy for someone who is vague abdominal pain or just discomfort and other symptoms, and we do the colonoscopy, we find diverticular disease. But if they are symptomatic, the commonest symptom will be left iliac fossa pain and features of diverticulitis. This is up to 25% of patients might develop that. It is very common here in this country. In each call, you will find one case of who present with diverticulitis. They present with left iliac fossa pain, and what else will be the presenting symptom apart from left iliac fossa pain? Anyone?
Maybe tenderness, fever, or swelling.
Okay. So they can present with fever, they can present with features of SIRS like tachycardia, hypotension, and then left iliac fossa pain, and clinical on examination, they will find tenderness, rebound tenderness, and it will be mainly in the left iliac fossa. Okay, so the first thing we think about in elderly people, it will be diverticulitis. Okay, so what is the other presentation? So sometimes can get worse.
Rectal bleeding.
Bleeding, yeah. So it is one of the cause of major bleeding. Major rectal bleeding can be due to diverticular disease. Most of the time, the bleeding will settle spontaneously without any intervention, but we'll talk about that when we come to the management. So in this case, the patient might present with rectal bleeding and might present with signs of shock, depending on the degree of the bleeding. Okay. So the presentation will depend on the amount of blood lost. We know the stages of the hemorrhagic shock. Do you? Stage 1, if you lose less than 750. 2, if you are losing 750 to 1.5 liter. 3, between 1.5 to 2 liters. And 4, if it is more than 2 liters. So the presentation could be, he might present with normal vital signs, or he might present with just tachycardia, or in severe cases, the patient might present pulseless, confused, and unrecorded blood pressure. So depending on how much amount of blood he lost. Okay, the third presentation is perforation. How do they present?
Localized or generalized peritonitis.
Okay, so they might either develop localized or generalized symptom, like you might generalized tenderness and rebound tenderness and rigidity. And there is a staging system for that. If you do a CT scan, if it is localized, do you know what's the staging system we use for this?
Classification.
Hinchi.
Formal
Hinchi. Very good. Hinchi classification. So what is Hinchi 1?
Pericholic abscess.
Pericholic abscess or inflammatory phlegmon. Yeah. In the site of, yeah. So well localized. And Hinchi 4?
fecal peritonitis.
Fecal peritonitis.
Fecal peritonitis. And Hinchi 3?
Purulent peritonitis.
Purulent peritonitis. And Hinchi 2 when you have pelvic collection and pelvic abscess. Okay. Does that make any difference? The management? Is there just academic things that Hinchi 1 and 1, 3 and 4?
Determines type of intervention.
Very good.
Surgical interventional radiology.
Okay, very good. Talk about that in detail when we come to the management. And even if you're doing intervention, again, can influence the selection of which criteria will go for. Or either you will go for laparoscopy, wash out drains, or you go for Harman's procedure if you have fecal peritonitis. We'll talk there when we come to the management. So, but it will make difference. A fistula, what kind of fistula you might get?
Colovacycle.
Yeah. This is the commonest one, colovacycle, 65%. Yeah. What else?
Colovaginal
Colovaginal, yes.
or coloenteric
Coloenteric, yeah.
or colocutaneous.
Colocutaneous. This is the 4 fistulas that you might get. The commonest one is colovacycle. What will be the presenting symptoms in colovacycle fistula?
Hematuria or fecoluria.
So, yeah, the content will pass from the high pressure area to the low pressure area. So, from the colon to the bladder. And the content of the bowel is either feces or air. So, you will have hematuria. The patient will say, I'm passing air bubbles when I pass urine. Or fecaluria, that means he's passing feces in the urine. Or he might present with recurrent urinary tract infection as well. Okay. Is it common in male or female?
Colovacycle is common in male.
Female.
Colovaginal is
No. We'll come to the colovaginal. Because that is mainly, that's just females. But tell me about the colovacycle. Who say males and who say females and why?
common in male.
Okay. So to make it easier,
There's no
to make it easier for you, I will say common in male, and in females it is common in patients who have previous hysterectomy. And the reason they get it more because we don't have, so usually the uterus is lying in between and forming like a barrier, and they less likely to develop the colovacycle fistula if they have the uterus in between. Okay. That will be the reason it is common in males rather than females. The colovaginal fistula, what will be the presentation?
Vaginal discharge or
Yeah. Again, discharge of feces or bubbles from the vagina. So again, the bowel content in the vagina, that will be the presenting symptom. So we'll come to the management of all this when yeah, say that again. Someone is asking question? No? I saw someone is asking question. No? Okay, so we'll move on. We spoke about the Hinchi classification. Okay, so what investigation would you do for someone who present with severe left iliac fossa pain, fever, and tenderness and rebound tenderness? Patient present to you in the emergency department. What investigation would you do?
can do a plain radiograph, ultrasound, of people.
Say that again, because I realize there's some interruption. Yeah.
We can do a plain radiograph,
Okay. So we
ultrasound, and CT scan.
تمام. طيب بنبدا روتين بلاد انفستيجيشنز. اوكي. اللي هي بنعمل فيها شنو؟ بتعمل الفول بلاد كاونت. الفول بلاد كاونت عشان نلقى فيه شنو؟ تلقى التوتال وايت سيلز هاي والنيوتروفيل. Yeah, and neutrophils, yeah, mainly, and the CRP also will be very high, indicating infection. Anemia depends on what's the presentation. If they're presenting with bleeding, then you will find a decrease definitely in the hemoglobin. Chest X-ray, you might see free air, but it's not really common. It is common with perforation of peptic ulcer disease. Is that right? Yeah. So if you have perforated peptic ulcer disease, they usually present like 60-70% will present with air under the diaphragm. But here, they will be localized air locules. So sometimes you'll not be able to see it in the chest X-ray. Also, you can do imaging in the form of CT scan. And the CT scan here, example, this is a case of diverticulitis. We can see the thickening in the colonic wall. We can see the free air. There is another arrow here pointing to the air there. Or you can see the collection, whether it is pericolic abscess or pelvic abscess or just generalized purulent peritonitis with pus all over the place or feces sometimes. So it will give us, and we also use the CT scan to differentiate from other possibly differential diagnosis for the severe abdominal pain and the acute abdomen. We don't do colonoscopy at all for someone who present with the diverticulitis, and should be avoided completely. We can do it, yes, if someone who present with diverticular bleeding. We do it in the following day when things settle to find the cause. We use the colonoscopy for diagnosis of diverticular bleed and for management of that. But regarding acute diverticulitis, we don't do it acutely. We prefer when the patient settle completely, discharged from the hospital, we bring them back in 6 weeks to 8 weeks time to do a colonoscopy. And that will be mainly to rule out other causes of that presentation, to rule out cancer or inflammatory bowel disease. Can you all hear me?
Yes, all clear.
Okay. Because some people are writing in the chat that الشبكة سيئة جدا، يا ريت يكون في تسجيل. أنا الحقيقة ما قدرت أسجل من هنا، لكن أخونا مستر أحمد عمر يفتكر بيحاول يسجل، كان لو ما هنا بعدك ممكن نعمل أوديو في النهاية إذا ما قدرنا نسجل.
لا التسجيل غايم.
التسجيل غايم الحمد لله. لا كده تمام. لا تمام. That's good. اوكي طيب نرجع تاني لموضوعنا اللي قلنا الانفستيجيشن coloscopy should not be done in the acute setting. تمام. ليه ما نعمله؟ ليه ما بنمنع شنو؟
Cause perforation in the acute setting.
Very good. لأنه if you try to do it in the acute setting definitely will end with perforation. نحن diverticular disease دي حتى لما ما يكون present with acute diverticulitis, you have to be very cautious when you do the colonoscopy for patients with diverticular disease. Yeah, the reason for that you can see in this colonoscopy here, you can see multiple diverticular disease. المشكلة هنا إنك sometimes you cannot differentiate between the lumen and a big diverticulum. You will think that is a lumen and you will go in with the pressure from the scope and the air. Okay. That can cause perforation Someone is asking question, what do we do if rectal bleeding and diverticulitis coexist together? We are also not doing a colonoscopy. We shouldn't do it. If someone is presenting with acute abdomen, even with bleeding, we don't go for the colonoscopy. Most of the time, the diverticular bleed will settle without an intervention. And even in the literature, they said it is very unusual to get the two presentation together. I mean, they either present with acute diverticulitis or we present with a diverticular bleed, and that one should usually be painless, abdomen soft, no signs of tenderness, and they just present with the bleeding. But even if it is rare and it happened to you, just don't do any colonoscopy. Most of the time, the bleeding will settle spontaneously. So correct the anemia, transfuse if necessary, and wait, it will settle. Okay. So management of patient with acute diverticulitis, we shouldn't consider colonoscopy at all. So we resuscitate the patients, okay, and we treat them with broad spectrum antibiotics. We have to make sure we are covering the gram-negative bacilli, we are covering the anaerobes. Here we usually use augmentin 1.2 gram 8 hourly, or we can use cefuroxime plus flagyl 500 8 hourly. Rarely we need to upgrade. Most of the time they will settle, but if they are not improving, we treat them according to the blood culture results then. We might need to upgrade to tazocine or meropenem depending on how they respond to treatment. And certainly if they have perforation and they have collection, we'll come and talk about that in detail. If they have collection, we'll deal with it according to the size of the collection. Is it less than 4 centimeters? Is it more than 4 centimeters? But we'll come to that in the next few slides. So patients who have diverticular bleed, how do you manage them? Someone to tell me?
First resuscitation, then conservative management. The first place.
Yeah, the most important here is resuscitation. Make sure you will follow the ABCs. It's a patient, sometimes they present with shock, so make sure that airway is patent. B, and then put 2 large bore cannulas, take the blood samples for cross-matching, the routine bloods, okay, coagulation profile, and then start to give fluids. We'll give 1 liter stat, and then we give 2nd liter and monitor his input and output and response, the vital signs, get the blood ready. If he is not responding, then we have to go to the next step, transfusing the patient. So we will do the resuscitation, and after the resuscitation, then we divide patients into categories. Okay. Most of the time, again, we repeat it, the bleeding from diverticular disease will settle spontaneously. Okay, so in the following day, say the patient is stable, okay, but he still have ongoing kind of bleeding. What do we do? Stable patient responded to resuscitation, but is still having ongoing bleeding.
Colonoscopy.
Very good. So we'll do a colonoscopy, and that is mainly to confirm the diagnosis, to make sure you're not bleeding from other reason. And we can use it also for the treatment. What treatment can we do with using the colonoscopy? So you can see here is the diverticulum.
Injection sclerotherapy.
Injection sclerotherapy. This we commonly use it for that one we use it for hemorrhoids most of the time, is it? Yeah. So here we can see the diverticulum with the blood vessel stretched, and they can cause bleeding inside. What do you think what they are doing here? Here in the first slide, top one on the left, they inject it.
Clipping.
Okay, so they injected adrenaline here, and here they started to apply. These are clippers we use to control the bleeding. We use even when we do polypectomies. If there is bleeding from the base, we use the same clipper. So we just apply the clipper and fire it. We usually either fire it directly on the bleeding vessel or apply two, one in each side, like this one here. Okay, so we can do clipping, we can do banding, we can do injection of adrenaline, and there is other stuff that we can use, hemostatic powder or glue, and we can use it also. So there is 4 different measures, but don't use the injection of adrenaline alone. It has to be a combination of 2 different modalities. So patient is stable, you found the cause, then you can treat it with using the colonoscope. It will be more specific, targeting the area of the bleeder. If the patient is unstable, okay, or if someone who had failure of endoscopic treatment, then we have to consider to move on to angiography and embolization. They can do the embolization using coils or like cyanoacrylate in the small specific. It has to be highly selective. You don't do the embolization for a big vessel. Why? You have to find the bleeder and just to embolize that selectively that bleeder. Why do you think we should not just?
Can lead to ischemic colitis.
Exactly. So it can lead to ischemia. It can lead to ischemia to the segment of the bowel. So you have to be highly selective. If the patient is refractory, has a refractory bleeding, and we tried all the measures and he's not responding and he's going deteriorating very quickly, then the last resort will be doing is there any role for surgery and resection in these cases?
Segmental resection, and if can't be localized, total colectomy.
Yes. So what is not common, it's only in less than 1%, and we rarely hear, to be honest, we rarely need to do that. But if you are doing it, do localized segmental resection. Usually they will know the site of the bleeding from either the colonoscopy or the angiogram, and we do segmental resection to that segment. If you do random colectomy for segment without localization, the end results will not be great, and you will find a very high chance of rebleeding. So you either do this, or there is no point doing random segmental resection, just guessing that could be the segment, usually in the sigmoid, so we should do this or that. So it has to be localized. Angiography, you can see they can detect the bleeding areas, and here they pass the catheter there, and then they do the embolization to that bleeding area. But it needs intervention radiologists to be available. It's not kind of service that available even here in this country. Is not available in each hospital. That is about the diverticular bleed and diverticulitis. Okay, so if we talk about diverticulitis, patient present with acute diverticulitis treated with conservative treatment, antibiotics. Patient went home and he's coming back again in months or 2 months time with the same presentation. Is there anything that you can do to stop that from re-happening? You change everything, dietary changes, and you dietary advice and change of lifestyle and everything, and it doesn't work. The patient keep coming with repeated attacks of acute diverticulitis. Is there anything that you can do for him?
Elective resection.
Yes, so we'll do elective, like usually it's sigmoid, we do elective sigmoid colectomy with primary anastomosis in these cases. Okay. So this is one of the indication of elective surgery in diverticular disease. This is just a quick summary of how do we treat patients with acute diverticulitis. So whether it is complicated with perforation or obstruction or fistulization, if it is very complicated with frank perforation, then we have to go and do Hartmann's procedures. This is on the right side of the screen. Okay? And if it is uncomplicated, then we treat according whether the patient needs admission or no need for admission. If someone has tenderness, high CRP, high white cells, and all that, so you admit him, put him on the IV antibiotic, keep him fasting, analgesia, and all that, and then reassess him in 2 to 3 days by repeating CT scan. If he's improved, then we can consider discharging the patient. If he's not improved, then we have to move to the top of the slide. If the scan showed like there is a collection, it depends on the size of the collection. So if there is an abscess, which is 4 centimeters or more, then ideally we should go for, what should we do if there is collection? I need answer. Can you hear me?
It's more than 4 centimeters for image-guided drain.
That's good. So if the collection is small, we'll just continue with antibiotic. But if it is more centimeter or more, then we have to go for drainage, and that we'll need. If you have intervention radiologist, we can do that, all right. But if you don't have it and the patient is not responding to antibiotics and all that, and is getting more sick, and you did a CT scan again in 2 to 3 days, more collection. So what will be the other option if you don't have IR? Most of the time we don't have intervention radiologists in the hospital. Even most of the hospital here, they don't have intervention radiologists. So what do? Patient not responding, he has a collection and all that.
Surgical drain, either laparoscopic or
exactly. So there is a role for surgery here. So we'll go if we have laparoscopy, we'll go for laparoscopy. If we don't have laparoscopy, we'll go just for laparotomy, and then we deal with it. So if we're doing laparoscopy, like here, this case here, we're doing laparoscopy, we can see the colon there and the small bowel stuck to it here, and there is abscess formation. What do? So we do suction and drainage, wash out with 4 or 5 liters of saline, and then we put drains. You can put 2 or 3 drains in the abdomen. Is that okay? Can you hear me?
واضح.
أيوة, دي another example. برضو again, pelvic abscess. You can see the drain on the left side, in the left image here. So I'll go back again, and you can see the port going in, and he's just using the trying to find the area of the interlobe abscesses and draining the abscess and doing the washout, and just leave the drains. And most of the time when you do that, patient will settle. Sometimes they come after 6 to 8 weeks, and you can hardly find, like you can either find mild diverticular disease. So that will be like all needed is just to wash out and drains, and no need for people before used to do more aggressive surgery, going for Hartmann procedure for anyone with diverticular disease. Things are changing nowadays with the change in antibiotics, presence of intervention radiology, and the role of laparoscopy. So they're doing less aggressive surgery compared to what we used to do before. I am sure you are doing that all the time, so you don't need. You're just removing segment of the bowel, which is has a perforation or whatever the complication is, and then just bringing the proximal end as end colostomy, and we close the distal end. Okay, so we have went through the management of diverticulitis, management of diverticular bleed, and the next thing will be the colovesical fistula. As we said before, it's very common in between the colon and the bladder, and less common in females, as we said, because of the uterus lying in between. So what investigation would you do for someone who presents with nematuria or fecal uria? What investigation would you do?
CT first thing, so that colonoscopy and cystoscopy.
Exactly. So we do the CT scan, and that can show the contrast, going from one area from the colon to the bladder. Or you can see, you can also do a colonoscopy. The colonoscopy mainly to rule out, to make sure we are not talking about malignancy, to make sure there is no colonic cancer or rectal cancer, or cystoscopy for the same reason, just to rule out any possibility of bladder carcinoma. And at the same time, you can see the area of inflammation and duration, but most of the time, will not be able to see the fistula per se. Okay, so the treatment for that is, what is the treatment for colovesical fistula?
Sigmoidectomy and resection of the involved area in the bladder.
The first part of the answer is correct. So what we do is sigmoid colectomy. The main pathology is not arising from the bladder, it's arising from the colon. So once you do the sigmoid colectomy, and then you can pinch it off from the bladder by doing blunt dissection. Okay, so most of the time there will not be visible defect in the bladder, or you can find a small hole in the bladder, and catheterization for 7 to 10 days will be more than enough for that to heal. Sometimes if the perforation is big, then you can go and try to repair it, but again, we are not going very aggressive here. We shouldn't go very aggressive here when we deal with the bladder site of the fistula, because most of the time when you leave a catheter in, that should be able to look after it. If you leave a catheter for 7 to 10 days, some people just inject methylene blue in the bladder and see how much is the leak, but we don't do that routinely. Most of the time, we just pinch it off, take it off from the bladder, and leave a catheter in the bladder, and it will heal. Once the source is removed, diseased sigmoid colon is taken out, that should look after the pathology there. This is just here another diagram showing Siberium, actually, anyway. And you can see the long arrow here is showing the fistula, and the short arrow here showing the collection, and the dotted arrow going to the bladder. We can see the fistulization into the bladder. Okay. One more presentation we didn't speak about is obstruction. Can it lead to obstruction? Can diverticular disease lead to obstruction? And how? And is it a small or large bowel obstruction? Yes. If someone has
healing by restriction.
Yeah, so recurrent episodes of diverticulitis, and that can lead to thickening of the bowel wall, fibrosis, and eventually it might end with stricture. And we can encounter that when we do the colonoscopy. We just find that the lumen is very narrow. We can't pass the scope through, or you can find it when we do a CT scan. They can comment on that as well in the CT scan. But that can lead to large bowel obstruction. Can it lead to small bowel obstruction as well, diverticular disease? Can diverticular disease of the colon, not of the small bowel, lead to small bowel obstruction?
Yes, sometimes if it is complicated by perforation, it may lead to ileus, or part of the bowel loop may be entrapped around the perforation. That's
good. So yes, the answer is yes, it can lead to small bowel obstruction indirectly. So there will be inflammatory phlegmon, pericolic collection, and the whole area is just, the small bowel can get stuck to that area, can get mechanical small bowel obstruction, or functional like ileus from the period peritonitis and fecal peritonitis. So it can lead to small bowel obstruction as well indirectly. Okay. The topic, I think we covered all the aspects of it. So it's a small topic, to be honest, but it is very common for people who are coming abroad. You will see that every time you are working as a casualty, like daily, you will see a case of the complicated diverticular disease. I'm just saying we are seeing cases nowadays in Sudan. We used not to have cases of diverticular disease, but now we are seeing few patients who present to us with diverticular disease, even with complications from there. Any question? Let me check in the mobile also. No, the last question was combination of rectal bleeding and diverticulitis together, what we should do. So any other question?
Mr. Shani, there are new researchers talking about the role of the microbiota in the management of the diverticulitis.
Yes, the microbiota. So when we talk about the microbiota, there is alteration in the imbalance between the protective preventive bacteria and the harmful bacteria. So if there is imbalance, that can lead to the formation of the complications like diverticulitis. So there is role of this microbiota in all the inflammatory bowel disease, and there is a role for that in the management of diverticular disease. So because they found there is association, and it has a role in preventing patient from developing recurrent episodes of acute diverticulitis or complicated diverticular disease. So the answer is yes, there is a role for that. The same like inflammatory bowel disease. When we talk about Crohn's and ulcerative colitis, there is a role for microbiota in the management of this disease. Any other question?
It's not applicable in the hospitals yet.
No. This is under research. So but it's more like they talk about it more when we talk about inflammatory bowel disease rather than diverticular disease. But it has a role. It has a role. Any other question? Okay, so if there is no more questions, that will be the end of the session. Till I see you in another presentation. Thank you so much for joining, and we'll see you again, inshallah.
Thank you.
شكرا دكتور نادر for دكتور شاني for elaborate talk.
نادر ما بعيد. نادر ما بعيد يا احمد. قريب معي. قريب معي. يبلغ ان شاء الله. Thank you very much for giving me the chance to present. Then.
يديك العافية. الإعلان كان short notice عشان كده participation شوية ضعيف، لكن إحنا we recorded the session and we'll send it to the group. I will hope إنه السيشن تستمر. We know إنه الناس are very busy المشاكل الحاصلة وكده، لكن
والله صحيح صراحة يعني
we'll be able to continue sessions.
إن شاء الله. إن شاء الله. العفو. الله شكرا لكم الاستماع. شكرا لزين.